All right, let's dive into the absolutely incredible world of reconstructive surgery. This is a field where surgeons perform what look like actual miracles, piecing together not just bodies, but, well, people's lives and identities.
I mean, think about that for a second. It's a huge question, right? When a part of someone is just gone, taken by disease or a traumatic injury, where do you even begin to restore it? This is the core challenge that drives one of the most complex fields in all of medicine.
And it really is a puzzle. But we're not talking about your average jigsaw puzzle here. This is one where all the pieces are living, breathing tissue, and the stakes, well, they couldn't possibly be higher. We're talking about situations that push the absolute limits of what is surgically possible. So picture a patient who's battling a cancer in their head or neck that just keeps coming back. Repeated surgeries and radiation have just wrecked the surrounding tissue. Or think about someone who survived a high-voltage electrical burn and is now left with this massive defect. You know, these aren't simple fixes. They're profound challenges to a person's ability to function and even to their sense of who they are. So how in the world do surgeons solve a puzzle like this? Well, they don't create a new piece out of thin air. Instead, they find a living one from somewhere else in the patient's own body and move it. And this brings us to the fundamental concept behind all of modern reconstructive surgery. It's called a surgical flap, and the best way to think about it is like this. Imagine moving a perfect patch of grass from your backyard to a bare spot out front. You can't just scalp the top layer of green blades, right? No way. You have to dig deep and take the roots with you. In surgery, those roots are the arteries and veins, the blood supply, that keep that block of tissue alive. It is, quite literally, a living, breathing patch-up job. And the procedure itself? It's just an incredible feat of precision. First, surgeons find a good donor spot, maybe the thigh or the abdomen. Then they carefully harvest that flap, making absolutely sure to include its lifeline, those crucial blood vessels. After they transfer it to the spot that needs it, they perform this incredibly delicate dance under a microscope, painstakingly reconnecting those tiny, tiny vessels to the blood supply in the new location. Okay, but here's the thing. Not all flaps are created equal. You can't just use any old piece for any old job. To tackle all the different challenges they face, surgeons have this whole advanced toolkit of techniques, and each one has its own special properties. So let's meet a couple of the workhorses in this field. First up, you've got the ALT flap. This one comes from the thigh, and it's super versatile, just fantastic for the delicate, detailed work of rebuilding facial features. But then, on the other hand, you have the CRM flap, which comes from the abdomen. This one provides a much wider area of coverage and can even include muscle, which makes it the go-to solution for really massive defects, like the ones you'd see from a severe burn. Different tools for different jobs. So that's the theory. But what does this actually look like in practice? Let's take a look at a type of case that Dr. Izawa Koshima, who's a real pioneer in this field, has had to tackle again and again in his career. Okay, so here's the challenge. The patient has an aggressive recurring cancer. Not only that, but the whole area has been blasted with radiation, which makes all the tissue there incredibly fragile and really hard to work with. This is pretty much one of the toughest reconstructive challenges you can face. And this is where things get so important. For surgeons like Dr. Koshima, the goal is so much more than just, plugging a hole. They're also artists. They're not just covering a defect, they are working to restore a face, a smile, a fundamental part of a person's identity. It's about function for sure, but it is also deeply, deeply about aesthetics and human dignity. Now, to pull something like this off, a surgeon has to combine a bunch of different techniques. So they might use that versatile ALT flap for the soft tissue coverage, then bring in part of a muscle called the rectus femoris to help fight off infection. Then they might use bone grafts to provide structural support. They'll even shape the flap in a specific triangular design to stop the area from narrowing later on. It's an incredibly complex, multi-layered solution. Of course, a surgery at this level is just fraught with risk. I mean, even with the best surgeons in the world, the human body can be wildly unpredictable. It's like walking through a minefield. And that's the question that must keep these surgeons up at night. What do you do when the best laid plans just go completely sideways, either in the operating room or during recovery? And this, right here, shows you the constant chess match they're playing. If lymphedema, which is this really severe swelling, occurs, they have specialized techniques to manage it. If the tissue they're working on is irradiated, the surgeon has to be extra careful in picking which blood vessels to connect to. And
In the most devastating cases, like a high-voltage burn where the flap just completely fails, the only option left might be the painful last resort of amputation. You know, the immense complexity and the unbelievably high stakes of this work mean that the old idea of the lone surgical genius, well, that era is evolving. The future is all about collaboration and sharing knowledge. And check out this number, 55. This really drives home the point that this vital surgical knowledge isn't being locked away in a silo somewhere. The information for this very explainer actually comes from the 55th in a series of webinars where surgeons from all over the world get together to share their toughest cases and their most innovative solutions. And that path forward? It is absolutely paved with technology and teamwork. We're seeing AI analysis videos being created to help train young doctors. We're seeing educational materials for patients being translated into tons of different languages. And there's this huge emphasis on collaboration, not just between reconstructive surgeons, but with the oncologists who remove the cancers in the first place. It's the whole shebang. So it kind of leaves you with this one final thought. In this meticulous, high-stakes world of rebuilding human beings, where every single millimeter matters and every single decision is critical, can you even tell where the science ends and the artistry begins? Or are they, in fact, one and the same?